be a revision for you because this is what we tackle every day in the lab, looking at differentials, good staining, interpretation, etc., etc. And why is it that I have, I stress a lot on this because, I've been trained in such a way in the US. I've had a supervisor called Marion, and she knew I liked doing differentials, and she was absolutely superb. So what she would do is she would make me sit. Can you hear me? Can you all of you hear me? Hello?
Yes, ma'am.
Yeah. So she would make me sit with her, and she would say, all right, here, take a look. Stare at it, see what you're getting, and discuss it with me. And in about 10-15 minutes, I would give her a diagnosis, etc., etc. And she would agree or she would disagree, saying, no, take a look again. And then she would say, take a look at these features in the differences. It was a good tech picks up what's wrong with the patient looking at the smear. But yes, history is important. But we in the lab never got history. We just went to the wards, picked up the sample. We did have an OPD next door, but usually we were not there. And she would sit, stare at it, look at it, tell me what you think. And she sat with me. Even after work, she would sit with me. Or sometimes she had the afternoon shift. So she would come a little early, call me a little early also, and make me sit with her. And that's how I learned how important it is to do good differentials and to pick up what could be wrong. What could be wrong. So I owe Marion Crawford a great debt of gratitude for having taught me. I think we will start. I think so there'll be some more coming in. All right.
Presentation.
All right. All right, guys. So the title of this presentation is blood smear examination, and the slide we have in front of you is. Can you guess what it is? Can you guess what this parasite is? Any idea? Of course, you got your smears at the other end. Can you guess? Anybody?
Malaria?
Pardon?
Malaria?
Yes.
Malarial parasite?
Yes.
PY-vax? PY-vax?
Yes. Tell me why PY-vax?
Ma'am, that gamete, I think so. What I recall.
No, this is not a gamete. This is a
No?
trophozoite. Look at the size of the ring.
Ma'am, it's been years now. So,
Okay. Anyway, so it's a good thing to talk about. So we do a little question answer bit also. So this is PY-vax, and you can see the ring is larger, and sometimes they don't even ask for it, and you have to pick it up for them. All right. Besides taking a look at the histograms and reports that come out from the machine. So preparation of the blood smear. There are 3 types of blood smears: the cover glass smear, the wedge smear, the spun smear. There are 2 additional types of blood smears used for specific purposes: Buffy coat smear, where the WBC is less than 1 × 10⁻⁹ per liter, and thick blood smears for blood parasites. So again, somebody's coming, guys. Please excuse us. All right, let's go further. All right, so I see that the cover glass smear not very popular in India. Those of you who've been with me at DCA, remember I bought these slides from America, and most of the slides in the US is done this way. Then you've got the wedge, very common, which you and I use. Then here the spun smear is you spin it down and you make the smear from the buffy coat. And then you've got the buffy coat smear, where the WBC count is very low, and thick blood smears for the parasites. Okay. So the wedge smear, which we are familiar with. So EDTA blood within 2 to 3 hours and collect it to mark on tube may change what you can't do if you're going to let it sit for so long. May change RBC morphology, such as spiculated prenatal cells. So that's an anomaly. Excessive amount of anticoagulant to specimen, we don't like. Old blood, long standing, can give you evacuation. A warm environment, room temperature may hasten changes. So when you're doing a wet smear, be very careful, pull immediately, because otherwise your morphology will change and you will get to see something which is not there. And if you have an excessive amount of anticoagulation, there will be a problem. And old blood we do not like, so we like fresh blood. Or you can do a finger stick and start pulling smears from there. Tell him to stop the doctoring later. This is so irritating. Okay, get it in. All right, so we'll come back. All right, so this is what we avoid, and in the procedure, we like to have our glass slides absolutely clean. The spreader slide using another clean slide at 30 to 40 degrees angle, you need that. Control thickness of the smear by changing the angle of the spreader slide. Allow the blood film to dry completely before staining. Do not blow on the slide. The moisture from your breath will cause RBC artifact. Now, I have always advised that your slides should be washed and then dipped in alcohol for at least to be overnight. Then using a soft cloth like a malmal, you clean the slide completely. You remove all the grease and keep these slides separately in the box. The spreader also is special. You get special spreaders, or you can use the cover slip, a special thick cover slip. You can use that, and you pull at 30 to 40 degrees angle. Depends on whether you want a thick slide or a thin slide. So it says control thickness of the smear by changing the angle of the spreader slide. And we request that you allow the film to dry completely before staining, because your breath has carbon dioxide, and carbon dioxide can actually change the surface of the red cell. And I bang my head in my lab to see that the slides are dipped in alcohol, and 80% of the time they're not. We order special spreaders, and if you found your own spreader, keep it separately, tag it and keep it. So here you have high hematocrit, so small angle, and here you have a low hematocrit, a large angle. So the blood will spread and then you pull. I hope you're revising in your mind what you did in class. And here you have a very nice, beautiful smear. You have the very thick when you pull, and then you have the thin, so the morphology can be observed. And in that little segment over there, you can write the name. Characteristics of a good smear: thick at one end, thinning out to a smooth, rounded feather edge. Should occupy 2/3 of the total slide area. Should not touch any edge of the slide. Should be margin free except for point of application. So these things you will have to keep in mind, and just revise what you did in class many years ago. Sandhya, any words of advice for this? Sandhya, are you hearing me?
Yes, ma'am.
Any words of advice? Or you're so used to the machines that you've gotten over this, is it?
Yes, ma'am, actually.
Alright, so this is what a typical smear looks like, starting with the thin and then thinning out towards the periphery. So you can see different types of cells below. Something is written in Chinese, I do not know what it is. But see the one in the middle. The red cells are evenly spread. You can see the platelets also. So on the other side, I think somebody has used a lot of pressure, and some of these cells are broken up. And on the right hand side, I think the slide was not washed properly. It's got a reddish hue. Can you see that? It's a little bit of an acid smear. It's very difficult to read differentials on this. Take a look. Alright, we'll continue. So you've got slide fixation and staining. And the stain we use is Leishman stain. Okay? It's a Romanowski type of stain, and this is used all over. So Leishman stain is a polychromatic stain. Methanol fixes cells to slide. Methylene blue stains RNA and DNA, blue-gray color. Eosine stains hemoglobin. Eosine granules orange, red color. The pH value of phosphate buffer is very important. Yes. So Leishman stain is a combination of methylene blue and eosine, and it is made, the base is alcohol. There are other procedures where you fix it with methanol separately, especially if you're doing other procedures for malarials and all. So here you go, the principle is methylene blue stains RNA and DNA blue-gray color, so your nucleus stains blue-gray. Eosine stains your red cells pinkish, buff pink. And the pH of the buffer is very important. If you have a very acid buff pH or a very alkaline pH, you will change the color of your smear. You will not be able to see the cells properly. An acid smear is reddish. An alkaline smear is dark purple. So staining procedure, thin smears are air dried. Flood the smear with stain. Stain for 1 to 5 minutes. Experience will indicate the optimum time. Add an equal amount of buffer solution and mix the stain by blowing and eddy bubbles on the fluid. Leave the mixture on the slide for 10 to 15 minutes. Wash off by running water directly to the center of the slide to prevent the residue of precipitate stain. Stain slide on end and let it stand on a stand and let air dry. So the way you flood the stain, the way you stain the stain, and the way you wash becomes equally important. Because I'm telling you, it's a pleasure to see a well pulled smear and a well stained smear. I do not like acid smears. I do not like alkaline smears. Nisha, we are always requesting you to be on time, because when we break in between, our audience doesn't like it. Every time you come in late, please don't do that. I'd appreciate that. Alright? So here you got to a stage where you've dried. You washed it and you dried your slide. Now, in the US, a very good habit we had is when you're using these little cover slips, there's a special staining rack specially made to put the cover slip and staining it the same way. And once you washed it, you have a hair dryer. And you dry that little slide, and you have a slide, a regular slide ready, and you have a mountant. So you put a drop of that mountant on the cover slip, and then you put the cover slip onto your slide. So this becomes more or less a permanent slide. Also remember that especially when you're suspecting something like a leukemia or a very bad anemia, doctors always ask for pairs. So what happens is, you put a drop, I think I've shown it to you. You put a drop on the cover slip and take another cover slip on top, and then you pull it. Okay? And you put it on a piece of paper and you say 1-1. Again you take another drop, pull it, and you say 2-2. So these become matched pairs. Let it dry, stain it, and mount it with a mountant. Are you understanding what I am trying to tell you? I don't think I have I don't have a picture of that. So you have to have your cover slips, clean dry cover slips. One drop on the cover slip, pulled, and put it on a piece of paper, a clean piece of paper, saying 1-1, 2-2, 3-3. You stain it, you dry it, and then you invert it and mount it on a slide. And you label one, Mrs. So-and-so, matched pair, 1, 2, 3, and all that. And especially when we're suspecting something like a leukemia or an anemia, we use matched pairs. Keep that in mind. And you can do the same thing if you with bone marrow. With bone marrows also, we do matched pairs. We'll come back to it again. Here we go. You can take a look. 2 acidic, reddish in color. On the right hand side, you've got 2 basic, very dark purple. And in the middle is a smear that's suitably stained, right? Can you see the buff pink red cells? You can see the morphology. You can see what below you've got a blast. And I think this is a monocytic picture, if I'm not mistaken. And the right hand side, can you see a nucleated red? It's one little cell in B on top. Purple nucleus with a red cytoplasm. It's an NRBC. It's a nucleated red blood cells. Stare at it. You see, when you have the acid smear, I would not be able to make what's what. Similarly, when you have an alkaline smear, it's all doozy. Are you able to see the slides simultaneously, guys? Because we've put it in presentation mode. So are you able to?
Yes, ma'am.
Are you able to follow as I'm speaking?
Yes.
All right. Which slide is this? Can you give me the title?
This is the title is
Staining procedure.
No, you're at the back. This slide, what I have right now.
Staining procedure.
It's done. Staining procedure is done.
And after that the slide.
Yes, it will take a little time.
There's no title.
So it's not showing up on the screen, but we have it with us. So we are looking
No,
at
you
it.
see it has to show up because we are doing it in presentation mode.
No, it's not showing on.
Where are you right now? It's on staining procedures only. It has stopped on staining procedure.
Okay.
No, you tell us.
So you go down now. You press down now. It will go down.
We have changed the slide. Which slide you can see?
Staining procedures only
Okay.
the written.
Yeah, so it will take some time. Yeah, it will take some time. You have changed the slide. It might come
No, I
now.
can see which staining procedure it is.
But we have the PPT.
I know, but that still, we thought that
Yeah.
you're at this slide. Thin smears are air dried, flood with smear with stain. That's it?
Yes, that's the
All
one.
right.
Yes, ma'am. Yeah.
Yeah.
After that.
Okay, now you got a 2 acidic or a 2 basic
Yes.
smear. Have you got this?
Yes.
It's
Yes,
changed.
yes.
It has changed.
We don't have it on our screen here. We have it on our phone. I mean, on the presentation which you sent.
It should
No
be
problem,
there.
it happens in the
All right. Now what I am
online.
at a slide which says histogram scatter plot. Can you see it? You got the presentation in front of you, right?
Yes, yes.
Yes, ma'am, but the right hand side it is empty, the box, on the histogram scatter plot. The left hand side is there.
Yes, now we can see it on the screen.
You can see it.
You can see
Yes, now we can see it on this one.
the
On our call, yes.
Sandhya. Sandhya. Sandhya.
Yes.
Would you like to explain the histograms, the printout of hemoglobin and all? I think everybody follows, right? WBC is 6.2, and so on.
Okay.
So is there a histogram? Can you give them a little explanation? The WBC, red cell, and platelet,
Okay.
and there's a scatter plot on the right hand side.
Right. So we have on the left hand side the green that is from the instrument, which on the left hand side gives you the numeric values. Then there are 3 histograms, one belonging to the WBC, the RBC, and the platelet. In fact, the platelet and the RBC histogram follow one after another because they come from the same channel. From 0 to 25 is what is measured, the platelet, and from 25 onwards to the 250 femtoliter mark, you have the RBC. So it's platelet that follows the RBC. Histogram. In terms of knowing what the value is, generally it's frequency of occurrence that happens on the y-axis, and it is the volume of the cell that is measured on the x-axis. So between 0 and 25 you have platelet. Between 25 to 250 you have RBCs. Explaining in short, ma'am, do you want me to cover anything on the malarial parasites or something?
If you want, yeah.
Okay. Right. So when you have malarial parasites, they are measured, or they are encountered in the RBC channel between 0 to 25. What you see, or from the beginning of the histogram, there is a small peak that you will find, which is registered as malarial parasites, because this is the area which is dedicated to any debris, to any RBC fragments or platelet clumps. Once you encounter a small area in the between the beginning of the RBC and the base, in that case, the malarial parasites would be found in that area. Then coming to the first histogram that we have the WBC histogram. Generally, it is the lymphocyte, the mixed population, and the neutrophil population, which you are seeing on the histogram. The lymphocyte are the ones that are measured between the base of the histogram, that is from 0 till 300. You have the WBC histogram. From about 0 to 75, you have the lymphocytes. From 75 to about 150, you have the mixed population, and from 150 to 300, you get the neutrophil population. That's probably something that I'm telling you from on basis of my experience on the Sysmex analyzer. Different analyzers have different populations which are identified based on their sizes. So basically, it is frequency of occurrence on the y-axis, and on the base or the x-axis, you have the size of the cells, which is identified by the histogram. On the right hand side, what you see is the scatter plot. The scatter plot again, it's based on two dimensions. So here it is the side fluorescence that is taken into consideration in the y-axis, and you have the side scatter which is taken into consideration on the x-axis. Based on this, the various populations are classified. So the first purple population that you see is the lymphocyte. These are the smallest size cells that you get. Then you have the monocytes, which occur slightly ahead of the lymphocyte in terms of size as well as fluorescence. Then as you move still further, you come across a population which is the neutrophils and the basophils. So I believe this should be the SMICS or the Mindray data plot that we have seen. Ma'am can clarify. And then you have eosinophils. So eosinophils, these are the most dense cells that you have, and seen on the scale of side scatter, you have maximum density in the eosinophils, so they appear on the right hand side of the scatter plot. And in terms of fluorescence, they are very small, they have less fluorescence, so that is why they occur in the lower half of the scatter plot. Ma'am, that's it.
Yeah. Are you understanding? I think she's very explained it very nicely, short and simple. I think these are Sysmex. The left hand side is definitely a Sysmex scatter. The histogram. I don't know about Mindray. I haven't seen about Mindray, where there's a mixture of neutrophils and basophils. Sandhya.
Okay.
I think Sandhya is going to talk about this. She has a whole presentation on this coming up. So I think we'll get into that. But I think she's given you a very, very fair idea of what it is. And on the left-hand side, you can see all the values of the hemoglobin, red cell, the indices, and so on. A little on QC in hematology, some of you were interested. Anything that is automated, which goes on the machine, has to follow a certain law. So since automation in hematology is a rule of law in every lab today, IQC and ECVAS have become important. And we are going to talk about this. I think I was telling Parul that I have 2 presentations on this coming up afterwards. The DAYS IQC deals with 3 levels of controls: normal, subnormal, and high. You understand normal, subnormal, and high, alright? So normal is within the normal range, subnormal is very low, and high is the abnormal low. Each lab has to take part in at least one ECVAS, that's external quality, and monitor results for non-conformances. Get familiar with these words: ECVAS, non-conformances. The DAYS IQCs are logged in a special register, and now each time, each machine has its own mean SDCV, Levy-Jennings flowcharts incorporated in the machines. But what I like is I know all my machines have Westland, but I like to log down my results every day in a special register, and end of 30 days work on the mean SDCV using Excel. So one follows Westcard rules, and usually I like to limit it to 1 to S, which is 1 point outside 2 SD units. S is for SD. Internal audit results registered and maintained every month. NC is registered with corrective action and root cause. Now, I think you all know that NABL and CAP insists on internal audits. And internal auditors are you and me, which have qualified with the NABL program. It lasts for about 3 to 4 days, and there's a little test to follow. And then you go and audit your own lab. But if you belong to hematology, you will audit chemistry. If you got chemistry, you may audit some other department. You cannot audit your own department. And there are certain parameters that one follows in the audit. And it's a friendly thing, but at the same time not too friendly. And non-conformances are given. and within about a week you have to find out the root cause, the corrective and the preventive action, and that has to be registered and shown for the auditors that come from NABL or CAP. Each hematology tab, each hematology tech must know the basics of mean, SD and CV. Now these are statistical parameters, very simple, and now with the Excel, we'll show you how to work it. There's no problem. And we follow mean, we follow standard deviation and CV percentage. And this tells you how good or bad your run is for the day. A CV of less than 4% is to be maintained on each parameter, hemoglobin, red cell, platelets and so on. Check for outliers, correct if cause is detected. An outlier is something which is abnormal. Can you see the red spots on the Levy-Jennings chart? It's gone above plus 2s and minus 2s. Can you see the slide? Are you seeing the slide?
No, ma'am, I don't have it.
It's on the
It's
screen.
not there on the presentation.
It's up
It's
there.
empty.
It
It's
has to be
empty.
there. Anyway, how come they don't have it?
Same presentation.
Because the same slide we have made into this.
Only one or two doesn't have, or everyone doesn't have on the screen?
No, we don't have it.
We don't have it. We don't have it.
This whole slide is missing, is it?
Yes, ma'am, it's missing.
Alright, let's go back to the slide. So anyway, we will come back to it. Then we said check for outliers, correct if cause is detected. NABL auditors do check your quality control data for internal and external QC. Hopefully you should not have any non-conformances. So this takes, usually the lab manager or the person in charge of the department looks into this, and you have to teach your techs. All techs are not trained into this. How to work the mean SDCV, how to calculate, and how to draw the Levy-Jennings chart. I told you your machines have it ready-made, but you have to look into this. I prefer that I register my readings every day for 30 days. I work out my mean SD and CV and take it from there, and I can draw my own Levy-Jennings chart using a graph paper. So we come to our indices, and this is a revision for you, remember? Medical technologists must know how to read histogram that comes of the automated CBC machines. This will give him or her and doctor a fair idea of the patient's anemia status even before the slide is stained and observed, right? So depending on the MCV, MCH, MCHC, you can take a guess what could be wrong with your patient. I'm revising, I think you all know the formulas, you should know the formulas. So mean corpuscular volume, it is the average volume of the individual red cells measured in cubic microns. So MCV is PCV upon red cell into 10. The normal value is 87 plus or minus 5 cubic microns. Are you seeing the slide? Have you got the slide? Interpretation of indices.
Yes.
The next indices is mean corpuscular hemoglobin, MCH. It is a content of hemoglobin of the average individual measured red cell measured in micrograms. The formula is MCH upon red cell into 10. The normal value is 29 plus or minus 2 micrograms. The mean corpuscular hemoglobin, MCHC, is the hemoglobin concentration per 100 ml. It's not 1, it's 100 ml of PCV. Please do the correction. It's 100 ml of PCV. It's a percentage, right? So MCHC is hemoglobin upon PCV into 100. The normal value is 34 plus or minus 2%. MCHC increases only in hereditary spherocytosis. So you have to follow, you have to take a look at the values, and it can tell you if this person is anemic or normal, and what type of anemia could be present. So we've got terminologies like normocytic, normochromic, when the values are normal, or you can say normochromic color, microcytic. So normochromic color is fine, and microcytic means the cells are small.
Small in size.
Right. Then you've got normochromic or you've got hypochromic, macrocytic. Hemoglobin is down, cells are large, and so on. You'll have to get used to that terminologies. All right. Somebody wants an explanation on this? So here we go. Different types of anemias. Look at the results. MCV 100%, MCH 29, MCHC 32. So this is a normochromic, the color is normal, MCH is 29. Macrocytic, take a look at the MCV, cells are large. Are you understanding?
Yes, ma'am.
Right. Then you've got hypochromic, macrocytic. You got MCV of 100 again, MCH is 25, is lower than normal, MCH is 31. So you got hypochromic, macrocytic. You have less color and you have cells that are large. Then you got MCV of 80, MCH of 29, MCHC of 30. So this is normochromic, the color is MCH is normal, and microcytic, take a look at MCV. Normochromic, microcytic. Then you have MCV of 79, MCH of 26, MCHC of 30. So here you have hypochromic, microcytic. Hypochromic MCH is down, microcytic MCV is down. So usually your iron deficiencies are this way, or your Cal minors. Then you got MCV of 87, MCH of 29, MCHC of 31. But normochromic, normocytic, all values are in the normal limits. But there is a sort of anemia present. The problem is there. Then you got MCV of 87, MCH of 25, MCHC 31. So here is hypochromic, you can see MCH is down, normocytic, MCV is normal. So these are the different examples of anemias that can be present. So these could be vitamin B12, it could be iron deficiency, and so on. That was the last slide. Any questions, guys? We will send you that page of. We are going to. I was just telling Parul that we are going to. I have two presentations on QC/QA as well as Westgard rules and so on. And I think there was a request for vitamin D also, and different types of anemias. We may do that. Would you all be interested?
Yes, ma'am. Yes.
Nazreen, anything on from your side?
And generally in histograms I have one problem sometimes, very rare. For a patient, we don't get any readings. Even if we run several times, we don't get. When a repeat center also we don't get. And then we have to report from the smear with the help of the pathologist. Has anybody come across this situation?
You didn't get any reading on the machine.
No reading. There was nothing wrong with the machine. Nothing
So
wrong.
from the smear, what did you get? Do you do a manual? Do you do a manual hemoglobin? Do you stain? Do you do a manual count? This is what techs
Yes,
are
sir.
supposed to know. Not only relying on the machines, you must know how to do it manually.
Yes. Then the tech did manually, then the doctor did manually, and then they released the report. 2 times last year it has happened. Before that, 1 year also, sleep patient. Only one patient in 1 year I got like that. I don't know if anybody has come across this problem or not. They
Sandhya,
have to do it everything manually.
Sandhya, when does this happen? LIP make sample? Sandhya, are you hearing me?
Yes, ma'am.
Could be a lipemic sample, ma'am. There may be, or your probe is choked.
No, there was no problem with the machine. We sent for interlab also, they also did not get on the machine.
Then something was wrong with the sample. Why didn't you spin it up and see what the plasma was like? Did you spin?
I think the technical department must have done that. We informed the pathologists, they must have done that. That's how they got the smear done then properly, and they reported from the smear then. With manual calculations then.
From the smear, what can you manually calculate, Nazneen? You have, see, listen, you have ferrocyanide for your hemoglobin, right? Let's go back to the manual method. Nothing तुम्हारे पास है. You don't have it. You should keep it, isn't it? In spite, we have a 5-part differential, but we always keep ferrocyanide. And I've got your ancient salis for red cell, white cell. We've got dilutant fluids.
No, we don't have that. We don't.
I think you should tell your bosses to keep it. In an emergency, it's always useful,
I
huh?
will suggest that.
In an emergency, Sandhya, what do you say? We are stocked with it.
Ma'am, generally when we come across such abnormal samples, what we do is we do a 1:2 dilution,
Mm-hmm.
50-50,
Mm.
and then we run it on the system. In case the indices has to be the same, in case the value of the parameters changes, then we multiply it by 2 and then we issue the result. So generally, lipemic samples or icteric samples, you can rectify it in this way.
So next time, Nazneen, try it out.
Yes, ma'am. I will try it out. And this now they have come up with new rule here that for pH of the buffer adjustment we have to have mandatory pH meter. The one that we
Yes.
are adjusting from 5.7 to 7.4 range. So we are using pH meter. I don't know what the manually litmus people must be using, or what are you all using in your labs? pH meter only every day or what?
No,
Litmus.
we go with the litmus paper, broad range litmus paper.
Litmus paper. Yeah, we were using that till now. Last year they came for the audit. DHA, actually this is from Dubai Health Authority, not from ISO, not from CAP. So they told to use a pH meter. Then we have to calibrate that also, pH meter,
Correct.
once in a year. And it's good, actually we need it actually. It's good that these people come and do the audit so that whatever we need we can get from the management.
I agree.
Our work stops with the management. Nowhere else.
Okay, any questions? Any questions, guys? I think, see, I told you it's short, sweet, and interesting. But if you're a new tech, I think none of you are new techs, you must take time to study your differentials. And then, of course, you can compare it to your histograms and scatter plots. We were taught the very, very tough way. And we started off an SMA4 60, and we had the Coulter, the original Coulter, and then we had H3600, the Technicon H3600.
What are you doing for QCs for resetting the lab mean? How many times in 1 month you are resetting, or once in 2 months the lab mean? Because now, ma'am, we are doing what you said, that manual also, and we are doing automated also. When we reject the run, I am not excluding the run from the QC. After every 60 runs, 90 runs, we are re-establishing the lab mean. So when are you all?
See,
Second
I'll tell you very frankly, we are not doing exactly what NABL requests us to do. We are doing a very rough estimation, but I would suggest if your mean changes, everything will change.
Yes, yes.
If you have an outlier, so if you have a mean that's constant, your SD will be constant, your CV will be constant. So on the automated machines, you have to be careful. Sandhya, what do you say? Sandhya? Is she around?
Ma'am, yes, ma'am. I'm sorry,
No,
lost
she
the
was
thought.
saying about mean, checking it once
Yeah.
in 60 days, 30 days. I think you should check mean every month, 30 days.
Every
As you
month
should
is
check SD and CV, huh?
Re-establishing, not checking. The calculation is done every month.
Mm.
New value is taken every month. There are some times when now the machines, they are having a button in one shot. You can re-establish everything. So when you press that button, the mean gets calculated again after 60 runs, 90 runs. So when are you all re-establishing your mean?
I don't think that is the habit here. I haven't heard of it. I haven't heard of it.
That is not practice usually. It depends on what the laboratory has decided. We generally take a batch of at least 10,000 samples before we establish a laboratory mean, and after that is done, only adjustments can be, because it depends on the type of samples that are being sent to the lab as well. So generally, the mean is not the best average that you're getting. It's based on the population, and based on that, only the adjustment can be recommended.
But Sandhya, you're talking of
So
normal
with the new
normal
law,
people.
with the new law, you have to re-establish, no?
Yes,
With the new law.
yes.
So how many runs you are taking? That's what I want to know. 60, 90, 150, 180. How many runs you are
They
taking?
work from batch to batch, no?
Correct. Understood. Understood.
It depends on the manufacturer actually. They put in their recommendations in the pamphlet that is sent to them, and once you have read it, you can establish a mean for your laboratory based on the recommendation of the manufacturer.
Yes, ma'am.
Yeah, that makes sense.
Yes.
But you should not manipulate, huh? You should not manipulate. There are people who know
No,
to
you cannot.
yeah.
Another issue is new technicians, they are missing the NCs and correction. If they are according to the sample load, we have to run it in the evening also. So sometimes they get lazy or high sample load. The NC paper is there ready. They miss the NC to put the NC. So they're coming back tracking in the morning. What happened in the evening is also a big headache.
But haven't you established that after so many samples we will run another set of controls?
Every day in the evening, in the morning 2 levels, 3 levels. In the evening, any one level. Then second evening we change the level. Third evening we change the level. So evening one level we can run,
But
not the
then
normal
you
one.
have to drill that.
Okay.
If your techs are new, you have to teach them.
Yes, yes. So that disciplinary thing is becoming headache. Anyways, we are dealing with that, no problem. But this NC, logging of the NC is very important. They are checking, though all the auditors are checking hematology NCs very closely.
But really speaking, you should not have NCs in hematology. Sandhya, I don't think we have problems. I'm talking from my experience working in the lab. Huh?
Like correct, every day if your QC is good, you should not have outliers at all. Correct it is.
Okay. Anything else, guys?
Another problem is this QC, acquiring the QC, same lot, same batch, lot numbers changing, how many to order. They are very expensive. Everywhere in the world they are expensive. So I wish now I've suggested also many times these people who are on the websites also they should have the provision to enter the date. Once 2 weeks are over, they should not accept that batch. Like these now new generation machines they can do, but I feel the technology is still primitive if it cannot reach that stage now. So we have to keep going. If the supplier is not supplying, then we have to keep going with the same vial. So we have to, it is a problem, there's a challenge for ordering the QC. Because if we order more, then management will tell us the consumption under control. If we order less, the supply will not come on time. That is another headache.
So that's
It's
what
a very
that's what a
challenging-
lab
very-
manager does, na. That's what a lab manager does. She keeps an eye on stock. That stock keeping is equally
so
important.
what we do is we don't inform them. In the inventory, we don't count 2 extra. We always keep 2 extra, but we are not showing them that we have 2 extra. And then we tie up with the supplier and we sort it out our way.
Tricks of the trade. Tricks of the trade.
Yeah, we have to work it out our way only then. If management is, there is too much cut, then we cannot help it. Same way for Roche also, we are keeping one standby extra, and all the labs will keep one standby extra. If anybody is going out nearby labs, we will borrow from them. Like there are 3 labs, 4 labs in the area, we will keep good with everybody. If anybody is having any extra supplier problem or anything, we will support each other. Like that, I recommend we should all work with our nearby labs and keep all the QC people and lab managers in our hands in a group so that everybody can support each other like that.
Okay.
That's what we are doing.
Thank you.
Yes, thank you.
Thank you for all your inputs. Thank you, Sandhya.
Thank you, Sandhya. Thank you, everybody.
Thank you. Bye bye.
Next next
Thank you,
Thursday.
ma'am.
Next Thursday, Jaldeep speaking, right?
Yes.
Yeah, and he
Yes.
wants to see all your faces, huh?
Yes,
Okay,
ma'am.
so it should be a very interesting presentation. Right, guys, I shall see you.
Is he going to send the presentation a little in advance?
Yeah, I have to jog his memory. We've got what he sent. We'll send that to you, but he'll make some changes. But in the meanwhile, I'll ask him, and we can send to you all what he's given us. But I think he's going to do his own stuff. So let me jog his memory. Okay.
Yes. Thank you.
Okay.
Thank you, ma'am.
See you.
Thank
God
you, ma'am.
bless.
Thank you,
Thank
ma'am.
you, ma'am.
Thank
Thank
you.
you, everybody.
Yeah.
Thank you, everybody. Bye.
चेक करिए अपने टाइप्स करने लगा मोबाइल मैं ज्वाइन करिए चेक करिए रोज आई एम एडमिटिंग माई सेल्फ and I have changed टाइप्स as like so हमारा मोबाइल में भी as like it's changing in nice please see this like it's working presentation mode working
You put on charge. That's okay.